To solve the puzzles and mysteries of antenatal hydronephrosis, we have some galaxy of experts today. May I invite Dr. Sudarshan Suresh, who is a fetal medicine expert. Please welcome, sir. Then we have next Dr. Girija, who is a radiologist and also fetal medicine. Dr. Ranjani is probably pulled out at the last moment because of the health issues. We have a senior pediatric nephrologist, Dr. Subal Pradhan. Then senior pediatric nephrologist from ICH and Manipal Hospital, Dr. Jackie Sandhya. Please come on. Then we also have Dr. Rana Shah as our analyst, who is also a senior pediatric nephrologist from ICH and Manipal. So we welcome all 5 panelists, and since we do not have a panel here, and we request some of the surgeons we have with us. Amit is there, Gupta is there. You can check with the surgical point of view. So coming to antenatal hydronephrosis, we know it's defined as the dilatation of the pelvic peritoneal system or the distal urinary pelvic system. Thanks to all the USC's training during pregnancy, we are able to increasingly recognizing those fetal hydronephrosis. And it is considered one of the most common fetal anomalies, and the prevalence being 0.6 to 5.4%. It's bilateral in 70 to 50% of cases, and they may be transient in quite significant percentage of cases, up to 88% of cases. They may respond or rather resolve spontaneously during antenatal period itself, or even postnatally if monitored properly. They may sometimes require surgical interventions in 4 to 50% of cases. So whenever we have cases of antenatally diagnosed hydronephrosis, it's important that we have a proper monitoring, proper evaluating those cases to diagnose any underlying physiological abnormalities and also treat them up early, and also to treat them early to prevent renal dysfunctions. Now, there are many grading systems that has come that rather confuses us time and again. So it's an ongoing challenge. Our own ISBN has come up with the guidelines that came in 2013 that was focusing more on the renal pelvis diameters. Then there are other grading systems like Society of Fetal Urology grading systems, and our most updated ones is a new UPV's classification that has come in around 2021. So to discuss all these things, we have these experts who will be focusing on that. So this is a typical 23-year-old primary mother who has had a antenatal scan done in 20 weeks, and what we realize here is that apart from other features, what was significant here is the left kidney showing a significant dilatation. And that was repeated in the 3rd trimester. Again, that showed that the epidiameter diameter of the left pelvis was significantly raised from 19 km to 13 mm. Now, my first question to Dr. Sudarshan: how do you interpret these USCs when you see the antenatal scans? And to be more specific, is this hydronephrosis? How do you define it? What is the criteria that is based on? How do you diagnose them? And what are the grading of severity that you choose for antenatal hydronephrosis? What do you personally choose?
See, when I look at grading of antenatal hydronephrosis, identify finding some amount of pelvic dilatation during the pregnancy scan, especially the mid-trimester scan, is extremely common. But what it is what is the number. So when you do a mid-trimester scan, that's when all these are usually looked at. But sometime between the 18 and 22 weeks, we use a cutoff number of anything that is more than 4 mm in the antero-posterior diameter to determine whether there is some amount of fatigue. But up to 7 mm is considered pretty mild, and it's not something we consider significant. But what you can see in this picture, as what was described in the case above, so at 24 weeks you have some amount of pelvic dilation in the left kidney. At 26, 28 and 30 weeks, you can see that not only is the pelvis dilated, there is a progressive dilatation of the Kelesian system. The second thing that I look at in the pregnancy period to grade the severity of the hydronephrosis is one, the measurement. In the 2nd trimester, anything more than 7 is considered little significant. More than 10 is what I have a severe hydronephrosis. And we also look at the Kelesian dilatation, as I said. There are many gradings. One of the grading is the SFU grading. And the SFU grading, from a prenatal perspective, do we use that? We don't use that at all, because it's extremely confusing. If you look at the grading, it says sinus is open, intrarenal pelvis dilated, major calyces dilated. So differentiating your mild sinus being opened, the intrarenal pelvis being dilated is very, very difficult. And again, differentiating between the major and the minor cases in the prenatal period, especially obese patients, is extremely difficult. Again, the last grading where you say you're looking at parenchymal thinning, again differentiating cortical thinning, medullary thinning, prenatally. So this grading does not hold good in our prenatal period. We don't use it. But what we use is our UTD classification. We can move over to the next slide, which I can show you. Is this? This is exactly what I said. So in the mid-trimester scan, above 7 mm is what I consider. But there is a number of other parameters also what I see. I look at the parenchymal thickness of the kidney, and that's seen in the coronal plane. I look if there is any ureteric dilatation. I see if there is any bladder dilatation. I see if the liquor is small. At any point of time, irrespective of the dilatation of the renal pelvis, if there is dilated ureters or a dilated bladder, or there is echogenic appearance of the kidney with any cystic changes, then it goes to the red group, that is your UTD A2.
So this is the best system.
So this is what we use commonly. It's easy to put it across in the pregnancy period and easy to follow up also.
Yeah, even in postnatally you have these ratings, so that
correlating systems.
Yeah. So that comes. There are other systems like online system, that those are the latest one that's going to come. Right. So my next question to Dr. Girija. So what is the optimal time of doing antenatal USC, considering when you're trying to focus on picking up something normal in the kidneys? And what should be the frequency of monitoring of antenatal USCs in case you have already got something like antenatal hydronephrosis?
During the routine anomaly scan around 20 weeks, or sometimes even at the
When you first pick it up.
the early anatomy scan, we are doing at 60 to 70 weeks. That is the time when sometimes we can pick up a mildly dilated renal pelvis, which we again confirm during the anatomy scan. And then, as Dr. Suresh said, the measurements we note and just make a note of it, and we try to make the grade. And then we decide on further looking it again during the early third trimester, which is again after 28 weeks. So most of the early onset, late onset hydronephrosis may not be picked up during the routine anatomy scans. So the pickup is much more higher during the early third trimester scan, which is around 28 weeks. And why follow-up is needed is because this anteroposterior renal pelvic diameter is a dynamic measurement, and it depends on a lot of factors, the maternal factors, then maternal hydration, the fetal bladder filling, the position of the fetus, because ideally we should have the fetus in the prone position, and we see in the transverse section, we see the kidney both on either side of the spine, and we measure the pelvis. So we should have the ideal position. So this measurement may not be very accurate, so it's always necessary to follow it up to be sure that we are looking at a hydronephrosis. And once again, UTD A1, as Dr. Suresh mentioned, might resolve in UTD.
Might resolve
we need to follow it.
That's right. So the schedule, can you tell us the schedule?
Yeah, so if we are having a unilateral hydronephrosis or a mild UTD A1, then we follow it up again in the early third trimester, around 28 to 32 weeks. If it is bilateral, or if it is one of the most severe varieties, UTD A2, 3, then we need a more frequent monitoring. We try to measure every 4 to 6 weeks to see whether it's a progressive dilatation, which is going on to making the renal parenchyma changes and all that. And if we are also having additional findings suggesting lower urinary tract obstruction, then we need to do a more frequent follow-up, like maybe monthly schedules, because these are the cases which might need fetal interventions, and these are the cases which might persist in the neonatal state and go towards surgery. So there a lot of counseling and such things are required. And if this hydronephrosis exists with other extrarenal major or soft tissue marker abnormalities, then rather than just follow up, we need to sit with them to counsel them regarding karyotyping or even a measurement coordination might arise in those cases if there are additional findings.
So when you're doing a sonography, antenatal USC, what are the features that you look for in kidneys?
When we look at the kidneys, first we have to understand the severity, we have to grade them. So we need to measure, as I already mentioned, the AP RPD diameter is very important. Then we need to look at the calyces, which, as Dr. Suresh said, is very difficult to identify whether it's a central or peripheral calyces. cases. But we can make out parenchymal changes. We can see the parenchymal significant, there is a significant dilatation of the calyces, and the parenchyma looks very thin and hyperechoic. And we want to look at the ureters, whether the ureter is dilated. In antenatal scans, the ureters are not visualized. So just seeing it is enough to say that it is dilated, it is abnormal. Then we need to go down and look at the features of lower urinary tract obstruction if it is associated. So we might pick up megacystis, or we might find a thickened bladder wall. We might see the posterior tract is dilated. And additional extrarenal findings we need to look at in the antenatal scan is to look at the oligohydronephrosis, which is there because in severe obstructive cases we might find the lighter drops, associated pulmonary hypoplasia, IUGR, and we might even see the water fishes and all that. And renal dysplasia, once renal dysplasia sets in, we might see the renal cysts, sometimes the calcium ruptures, perinephric urinomas, or sometimes extraperitoneal rupture of bladder, that's a severe UTO. We might get fetal ascites also. So these are the factors which we have.
So, rightly said, ma'am. So, what we as pediatric nephrologists are more worried about when you're suspecting the lower urinary tract infection. That is something very sinister, most natally, then we need to follow it up. So, what would you, when you suspect, in the scans, that there is a features suspecting of lower urinary tract obstructions?
So, the first thing which strikes us in a lower urinary tract obstruction in antenatal scan would be the megacystis. So there are certain measurements of the bladder which we take a vertical height of the bladder in the first trimester itself. If it is more than 7 millimeter, then that points towards a megacystis. Then we need to follow it up again. So in the second trimester, if it is more than 2 centimeter, in the third trimester, it is more than 3 centimeters. So these are the measurements which we call as megacystis. This is one of the important findings. Bladder wall might look a little irregular. Bladder wall might look thick, like any thickness which is more than 3 millimeter. 2 millimeter is the upper limit for the fetal bladder wall. So if you find it more thick and thin, you might be able to pick up a posterior urethra which is dilated, especially when the fetus is boiling. If we are lucky to catch it at that time, we might get a sudden dilatation of the posterior urethra. And on a 3D reconstruction, sometimes you might even pick up the valve disturbing the posterior urethra. Then due to the reflux, we get the mega elevators, we get the renal hydronephrosis and the parenchymal changes and such things, and also the oligohydronephrosis.
These are the features that are exciting to look for. Okay, coming to Dr. Joy. So we talked about antenatal hydronephrosis. Can you tell us some of the causes of antenatal hydronephrosis?
Yeah, I think
I don't need to monitor because we've already discussed this. Can you just tell us the etiology?
yeah, I think we have just spoken that around more than 50% can be transient. So many of the hydronephrosis that we see actually are transient and they just improve on its own. But the ones which are more important are the ones which are causing obstructive. So we have things which are, why we need to know is because the etiology will determine the management later on. So one could be the obstructive types, which will be, the obstruction can be anywhere proximal to distal, like starting from the pelvic junction to the metacarpal junction, posterior valve. And the lower the distal the obstruction, more distal it is, the more chances of, the more the pressure effect on the kidneys and more the worse is the outcome. So this is one part of story. The other part would be the circulatory reflux, which will also lead to hydronephrosis. So these are the things we have to know. And apart from that, we have these malformations like kidneys, like megaureters, or some multicystic dysplastic kidneys, which should not be calling multicystic dysplastic kidney as a hydronephrotic kidney, because the NCBK will not have a connection with the pelvis, but they look on the ultrasound, they will look like a big cystic and a dilated kidney. So these are the things we have to keep in mind.
There are multiple causes, but then we get the transient and spontaneously occurs. So this comes to the next question: how do you counsel the family? Because many of the families getting a scan like this can be very kind of tension situation. They will be very anxious. Female can come to you and would ask you whether to continue the pregnancy or terminate the pregnancy. So how do you counsel these families? Any indications of terminating the pregnancies, if at all? Dr. Rana.
So, like any family counseling, is prenatal counseling should be followed by this general approach. But it has to be done in a very wide, comparable and patients. And at the start of the counseling, we have to check how much background knowledge the family has got. And you have to be very honest. It is not acceptable hiding in facts. and you have to pass the message very empathetically, speak in clear language, without avoiding any sort of medical jargons. And at the same time, you have to pass all the messages in chunks, not all together, so that they get enough time to absorb the message.
So it should be a very common real and human language that is here, and any guidelines that suggest whether intervention is required. And what do you do in this?
Basically, what I would suggest that we simple down, let me say what I would tell the parents that this, if your baby has the swelling in the left side of the kidney, and this is not uncommon. We do see it in pregnancies, like in 1 in 100 pregnancies, it is common, and most of them are not serious. But it doesn't cause any
So
problem.
you advise the family to continue the pregnancy?
With this background, the pregnancy should continue, and there is no indication for early delivery also, considering the fact of complication of pregnancy and termination is not required.
So guidelines say that termination is not unless there are some very gross external malformations. Now coming back to our case, now Dr. Rana has already suggested to continue the pregnancy continued, and there was a term male AGA baby born, weight was good, 2.9 kg, and then considering the child had, the fetus had antenatal hydronephrosis, again the UG scan was suggested, that was done on day 3, and then again showed the left pelvis diameters to be significantly enlarged. So this comes to our next questions. What is your interpretations about Subal, and how do you grade that severity? Just tell us the grading of the severity.
So the cutoff to define antenatal hydronephrosis again is different area. Many guidelines have different opinions, but anything more than 7 should take it further evaluation. So this child had isolated hydronephrosis left side hydronephrosis with a so as far as the RPT guideline comes around at least moderate to severe and as if you no record as for the SP grading is 8 to 4.
So it's a moderate SG grade 3-4, and if you look at the ARPD classification, it's coming to moderate kind of. So regarding the postnatal grading hydronephrosis, I think we have already discussed. We can skip this. Now we just skip moderate stage. So back to our case. So this child had postnatally had a significant renal pelvis dilatations. What will we do next, Dr. Rana?
So this is the postnatal ultrasound scan also shows that the left sided renal pelvis dilation is around 15 millimeter, and there is no other dilation in the area, and the area looks normal. So according to this guideline,
Would you wait, or you straight away want to do something?
I think we this scan is sequential scan just to see that the progression or any resolution of this pathology. If it is progressing, and it is or if there is mild hydronephrosis with the dilation of the aorta, then
Yes, we can perhaps
we have to look for
scan
the
that
upper and the lower obstructive pathology, like in the sense of including cystoscopy or DDPS scanning or CT scanning.
So in this case, considering the SG grade 3-4, it's a moderate to severe kind of hydronephrosis, what will you be advising them?
So basically, the next step will be to an MCG.
Perhaps MCG would be the next thing that would be, that's great. And close follow-up. So MCG to exclude the viewer, exclude any obstructive system, and then if that is not there, then you will be scanned. So what are the indications of MCG? Dr. Jay, you can just be brief on this.
Yeah, the first thing to know is whether it's bilateral or unilateral. If it's a unilateral hydronephrosis, we know that we are not dealing with something like a PUB, which needs immediate intervention. So we can, if it's a moderate to severe or at least more than 10, then the baby is otherwise fine, there are no urine infections or anything, we can wait a little and then get an MCG done around say 6 weeks or so. But if after doing another ultrasound, if we find that it is in the hydronephrosis is increasing, we do an MCG. But if it's a bilateral hydronephrosis, great UTD, variety with other problems, then our MCG has to be done.
Like maybe your bladder is taken over.
Is taken as other problems, yeah, with the suggestive of Pluto, and then we do an MCG right away. Because we do it right away within 48 hours and then plan the management accordingly. depending on what you get, BUR
The
or
message is if you have a bilateral hydronephrosis, gross, severely
it has to be done immediately.
delivery, and then you have a bladder features, suggestive of obstruction, then MCV and public clusters. Any indications of diabetic renopathy? Dr. Rana.
It's again, if it is a significant hydronephrosis, taking more than 10 millimeter or SFT hydronephrosis 3 to 4, then and the NCUG will show any reflux, then which child will need a scan or a C scan. Or if there is any hydronephrosis associated with dilated ureter, then you have if NCUG is not showing any reflux, then you have to do a dynamic scan. And it should be done in 6 to 8 weeks of age. It can be indicated in 3 to 6 months, and if there is further reproduction.
So message is that if you so it should be done at 6 to 8 weeks, around after 4 weeks in fact, 6 weeks is fine. So this was a scan that was done. We did first NCUG as we have discussed that it was normal, there was no VUR, there was no PV in this case, and this is the NGPA report that we got. So any surgeon would want to say, or like anyone just chip in with this kind of Antenatal, just comment on this.
This looks like a very nice obstructive curve with an outgoing curve, as you can see at the blue line. Yeah, that's outgoing. On the other side, of course, there is pretty decent drainage. So this is an obstructed pattern. That is the first thing. The second thing that we look at,
obstructive.
yes, it's obstructive. The second thing that we look at is what is the percentage function. And if percentage function is 27%, so obviously the kidney has been affected already by the obstruction, and the obstruction needs to be relieved as quickly as possible. So this child, we would recommend that this child undergo a bioplasty.
Thank you, sir. So intervention would be to do a bioplasty. So if there is any obstructive drainage and the differential functions here, as we have seen, is below 40%. Many of the centers that say below 35%. In that case, that becomes the indication to do surgical interventions. Bioplasty is the go. Now, coming to the next case. Now, this is again a 22-year-old primary mother. In this case,
From the prenatal counseling perspective, sometimes it's not as straightforward as you described in the slides. So sometimes we have these pregnancies where there is a unilateral severe hydronephrosis in the mid-trimester scan, and as someone who's been treating this for a long time, I do know that some of them, on progression, go into cystic dysplasia of the obstructive tissue, especially ones with severe hydronephrosis. Second, what we have also seen is the renal system in pregnancy, when we follow, is extremely dynamic in nature. As Dr. Anil put up in one case, he just showed up. I've seen enough cases where there is a unilateral hydronephrosis alone in the mid-trimester scan, and then it progresses to a bilateral hydronephrosis by 26 weeks. At 30 weeks, I see a picture of a lower urinary tract obstruction. So I would generally hold my horses at the mid-trimester scan and tell them that this likely seems to be an upper tract obstruction. But we need to have in perspective two things. One, things can change when we follow. Two, there can also be obstructive pathology which can impact the renal function, which can be kidney renals. So when we put these two across to the families, especially in the unilateral severe hydronephrosis, the next thing they ask us is, will the kidney retain function after birth 100%? Can you tell us? Because that is what is going to help me determine what I am going to do with the pregnancy. From my side, I still tell them one kidney is really good, so nothing is going to happen. You can be reassured. But then they start going and shopping to one house after the other. And at the end of the day, they come back to me and ask me, I have this one particular lady who we have unilateral severe hydronephrosis. I counseled them, I connected them to a pediatric urologist during the pregnancy period itself because it was very progressive, and she went through the pregnancy. She came back to me 3 years later for her next pregnancy.
So
at the mid-trimester scan, I had a 7 millimeter renal fibrosis. She asked me, are you going to tell me the same thing again? I said, no, this is very mild. She said, that's what you told me the last time at 20 weeks, and my baby has lost one kidney completely. They did some surgery, and the renal function of the kidney is hardly 10%. So it's not that easy to put it across, putting up classifications and tell them. In real life, I think it is little more challenging. So the word I use them during prenatal counseling, the kidney system in pregnancy is very dynamic. So you need to wait and watch.
Probably follow it up with other years.
Yes.
Then considering this kind of picture, probably the surgeons will definitely myeloplasty because the differential functions are different, badly affected. Now, next child and the next primary mother who's gonna scan during the last trimester, the third trimester of pregnancy. And what again you find here is very common to get a cases like this. You have the right renal pelvis of 12 millimeter, which is again significant, and also the left one being more greatly enlarged, that is 15 millimeter, and also the ureter looks enlarged and dilated, and bladder also looks thickened and irregular. Now, my question to Dr. Sudarshan. Now, consider this kind of very significant kind of findings that we see here. Probably the second trimester scan would have been better, but not as result. So, is there anything, any role of any fetal urine biochemistry, or any biomarkers which will tell you that how significant the postnatal pathology will be, and any scope of fetal surgical interventions? And if you are trying to do it, when would you do it, at what trimester, or what gestation of pregnancy, and where would you do it, in which centers, and what would you do it actually, if you want to do something to reverse this?
I go back to the previous slide. So this is a previous slide. So this is a findings that I put up at 37 weeks.
Right.
At 37 weeks, there is nothing there is to do. I only look at it when because the question was, do we go do any urine biochemistry, do we do any intervention? So the most common problem is when you see a picture of lower urinary tract obstruction where you suspect that this baby is having an obstructive pathology of the lower tract.
No, and if you look at the scan, you have the ureters dilated, you have the bladders thickened and irregular. It's just more of a lower urinary tract.
Yes,
and you have bilateral.
Yeah, and this presenting at the mid-trimester scan, at the 20 to 22 week scan, though at that point of time only questions arise as to all this. That is, do I need to do any urine biomarker? Do I need to do any biochemistry? I think a lot of it I won't be discussing in a talk later on. But to just sum it up in short thing, I try to investigate with the perspective of whether I need to do an intervention as to see how severe this renal pathology is. Is the liquor volume normal? That's the first and most important thing for me, the prenatal period. In the setting of a normal liquor in the mid-trimester scan, and I see only a picture of a hydronephrosis and a dilated bladder, do I go and poke the bladder to check the biochemistry? I don't, because I don't think it's warranted, because we have seen that the kidney is producing urine. And as long as the kidney is producing urine in the pregnancy period, I know that there is reasonable amount of function for the pregnancy to progress. The second aspect is that when do you actually go and do all this testing? I do all this testing when I am considering possibly there may need to be an intervention for this. And when do I consider an intervention? When there is a gradual reduction of the liquor volume, and I am suspecting that this kidney is slowly getting impacted because of the substructive pathology, and I need to have a little more objective parameters. And when I look at the objective parameters, I have to go and sample the urine biochemistry. The creatinine is of no use because it's excreted by the placenta. So I need to pick up some marker which is not excreted by the placenta, and one of that is a beta-2 microbiome. And the other is your urine electrolytes, because these electrolytes, normally what you tend to see is if.
So what does this tell you? What are these
I'm just coming to it. So what we've done is we have actually put a needle into the blood, and we have done one tap, and that is usually an old urine that we there for some time. So 24 or 48 hours later, we redo the sampling, and it serves two purposes. One, as I said, we see the bladder fills up, and two, we see how the biochemistry and the values are. So if these values of sodium and your calcium all are less than these values I put up across there, then it means that the kidney, the glomerular system is fairly functioning, filtration is still happening. If it is much higher, then it means the filtration is not happening well, and the beta-2 microglobulin value, rule of thumb, any cutoff above 6 is what we consider a little worrisome.
So if this biochemistries are favorable, will you go ahead and do surgery in this?
It's not a yes or no or a black and white answer with respect to that, because with respect to fetal urine biochemistry, there is not a great amount of consensus on how we need to use it for intervention. We actually try to use it in the other perspective. That is, when the biochemistry is getting bad, then probably that's when we need to go and intervene, because these pregnancies, when you intervene, there is a possibility that you may salvage some degree of renal function. So that's how I look at it. And if I move on, I will. So the beta 2 microglobin we use a cutoff of 6. The other thing, the newer peptide markers that are there, these seem to have more promise in recent studies because they seem to have prediction of renal function close to 85% of the cases. But it's still an ongoing study and it's still not available from a prenatal perspective for routine use. What we still do is a biochemistry and the beta 2 microglobin. And maybe in a few years' time, this is what we may be doing to study renal function.
So the same pregnancy in second trimester, have you
Yes.
seen this? Would, in this case, would you do something?
So as I said, at second trimester, if I see these favorable biomarkers, and if I see a little lesser liker coming down, and I see that the biochemical markers are slightly altered, and I see that the bladder is still filling up, which means there's some amount of functioning there, then maybe that's when we consider offering some sort of an intervention. And we have criteria where I have a kidney is little bright, there is hydronephrosis, but still I have not seen cortical cysts. The liquor is reducing, but it's still not anhydramnios. So an in-between state where it's not completely normal, it's not become completely bad. I wanted to prevent progression. Why am I thinking so much before poking the uterus? Because whenever we poke the uterus, there is a risk of pregnancy loss. We have a risk of preterm rupture of membranes, and to prevent that, that's what we do. So the surgical interventions, I think I shall be trying to explain a little more in detail. Between these two, the current consensus is that the shunting process to cycle the bladder is what is considered as the first line choice of management, still based on whatever evidence that is there. But what is more important is what I put up the last time. So this is a 2-year data on 50 cases of cystoscopy. 38% of the cases did not have a post-urethral valve. There was a distended bladder, dilated urethra, all classical of PUV, but it's not PUV. Because in PUV is the only aspect where we see that there is some amount of renal function that we can preserve and things. If I have a urethral atresia or severe stenosis, invariably they progress to renal failure even in utero period. So you have to think 10 times before we counsel these patients, because we can't simply say it is definitely a PUV. I put a shunt, everything will be alright. It's not like that. So for this particular case, if I consider it that there is a PUV and there's a likely is little bit reducing, the biochemistry is also a little bit becoming bad, then I might offer the patient a vesicombinatic shunting, but with a lot of counseling and making them understand what we are looking at.
When do you do it? In second trimester, or like during what period of gestation?
Yeah, we tend to do it, and that's what I said, when the liquor is reducing, whenever that happens. Say at 24 weeks and the liquor is a little bit reducing, I'm not going to wait till 30 weeks for the liquor to become very, very bad to poke in the uterus. But when I will not do it is in the first trimester. Any problem which presents prior to 18 weeks, it's uniformly bad, and doing any sort of intervention in this status only serves to convert mortality into a morbidity, which I wouldn't want to do for family.
And when you're counseling, do you tell them about the PUV? But the moment you tell them about PUV,
Yeah.
then you're indirectly revealing the sex of the child. So
That's the least of the botheration at that point of time. The family is facing a morbid prognosis. They want to see what is the best decision strategy, and most of them don't even ask the question.
okay. So criteria.
Yeah, I think we'll discuss it.
So back to our case. So this is a child who had a oligohydronephrosis and with very low lining. A5 was very low, and you see this had a significant dilations of pelvis also. The ureters were dilated and bladder also looked very bad. Now considering this, and so we did a scan at 2 days of life, and then it showed a significant dilations again. Now considering this, Dr. Subal, so what can be the possibility here now? Clear cut, and what would you do next?
Yes, so again, this is a clear-cut case of suggestive of LQ, blood obstructions. And as for guideline, you should go for early PCUG within 48 hours. And you may need to put a prophylaxis, and with the obstructions, then we have a surgical colic.
Right, so refer to pediatric surgeon, but before that, we want to do urine examination to rule out infections, and also when you plan to do MCUT, of course, you would be following this guideline. If you see it there, if you have a significant, can you discuss this as well? So if you have a moderate severe hydronephrosis, SFU grade 3 4, AP diameter is more than this time here.
So as far as this is an Indian guideline, what we are following that. So usually usually recommended at 4 to 6 weeks, but these conditions, if such LQ or obstructions, that should go for early, or if simply treating with severe obstruction, then.
So the message is like what Sir is saying. So if you have a severe bilateral obstruction, if you are suspected of LUTO, lower unit obstruction, then don't delay. In fact, do it as early as possible. Next scan should be within 48 hours, and then if that is picked up, then you need to do MCG straight away under antibiotic coverage. And then this is the MCG which we have done, putting the child on antibiotic coverage. Any surgeon would want to chip in with some questions here.
Just one issue. You said the ultrasound was done at 48 hours after birth, and a patient has got antenatal hydronephrosis of such severe degree. Why would you want to wait for 2 days without drainage before doing an ultrasound?
I think we should
No,
categorize
So
that's what I want to
normally
say.
repeat at 48 hours. So this
The
somehow
guidelines are guidelines. We are talking about an individual patient who's got severe bilateral hydronephrosis. You do not leave such babies for 48 hours and do it because the guidelines say so. That's number one. Number two is, what we would want to do is not wait again for the urine testing to be done. A baby who's just been delivered, there's no reason for the urine to be infected, right? So they should.
But there are very high chances of having urine being infected.
Only if you
and before
do some
pouring
into it.
sir, before
Otherwise no. Again, this is what I'm trying to say. Every patient has to be individualized. A baby born with such kind of findings, I would want to very urgently do an ultrasound, and I would, once the ultrasound confirms what you've shown, I would want to do an MCUG. If I'm concerned about UTI, I would actually do an MCUG from above, which means do a suprapubic puncture of the bladder and do an MCUG. So I don't even have to put in a catheter, and that would be absolutely sterile. So this again is a general guideline, is good that before doing an MCUG, please check the urine. But in this kind of a case, I would want to put in a catheter, do the MCUG and proceed as quickly as possible. So you don't wait for these things. Right? And of course, the MCUG now shows classic post-transfer valve. There is no vesicular reflux, which is something that we always look for. And I mean, this is a pretty classic valve. So the patient as quickly as possible now, once we would typically if the urea and creatinine are not very high and the child is not in urosepsis, which should not be delivered with us, then we would proceed to an early cystoscopy and sulfidation.
So nicely from sir.
Just a very simple question. In this scenario, as Dr. mentioned, would you categorize this baby
Normally this
in
is
the,
severe kind of
particularly in the baby? Given the antenatal scans that we've had, so this baby gets delivered and there is a consensus that we individualize and we don't wait for 48 hours postnatal USG. You would, given the situation.
So obstructed system.
Yes, so would you categorize?
Yes, definitely. Sir, what do you say? Obviously, with such an obstructed system, the first thing to do is that you would want to decompress the bladder. The moment you want to deliver the child, the first thing you can do is to decompress the bladder till the child is getting under surgical step.
Yeah. And is there any role of electrolytes in this baby post-birth?
Yes, they can be electrolyte imbalance. That has to be corrected. That has to be corrected urgently. That's what the guidelines also saying. Infant with posterior urethral valve should have early urethral catheterization, correction of electrolytes if there are any, and then also treat for any possible complications and also refer to surgical for surgical.
Sometimes the catheterization can be very difficult.
Yes, many times you've seen. I think many of our babies, we find it very difficult to do it in our ward or in our side. We call the surgeons to do the catheters. Maybe most of them sir knows. We always call your residents to come and do the catheters because we find it very difficult. But they somehow negotiate and do it.
So some work is not yours and you try to do it. You get it
That's what I said. Sir. We always call the surgical team to do it. People find it difficult.
Can I make a simple comment?
Sir.
So in the prenatal period, if someone finds something wrong, they always go to the pediatrician.
Right.
In the postnatal period also, if a baby has some problem, they go to the pediatrician. So you are the ones who will first see the patient. There is no doubt about it. But the natural history of any such patient who has a dilated system is that they will go to the pediatrician. But the pediatrician should leave these patients with the surgeons immediately after they are born, sometimes before they are born. And the surgeon will do whatever they can do and do the best for the patient. But at the end of the story, the surgeon and the nephrologist will have to follow up these patients for life for their better survival and delay their renal transplantation as much as possible. If necessary, some of them will not need renal transplantation. So that's the scenario. Leave the patient to the surgeons in the middle and walk with the surgeon in the same path after the treatment has been done.
So very often what we find is that post-PV, the monitoring of these children are very bad. So they don't go to the nephrologist, they don't come to the surgeon for a regular follow-up. Many of them come with CKD, the advanced stage. Many of them come with a very bad CKD later on.
Yes,
Probably
yes,
because they don't follow it.
I am pediatric surgeon. I always tell the parents that your children, all these children needs lifetime follow-up.
Right, sir.
It is not complete here. What I have done is not complete. He should be under lifetime follow-up, and when I am not there, there will be some other person.
Right.
Yeah, no, I just wanted to, carry on with what Professor Basu has said. But we must consider, whenever you see a PUD, there is the potential danger of ESRD with that patient. And with that kind of a thing, as you said, that they don't have a proper follow-up, either with the surgeons or the nephrologist, it's the problem of the system. We can't help it.
Can I say that we have a full 45-minute session on PUV?
Right, we'll have
And please don't take
Any indications of antibiotic
please don't finish
Thank you very much. We have PUV sessions coming up, so there will be a lot of discussions of the case per se, but this is just the last part of it, so the last line.
leave something
Some
for
tips
our
for the surgeons are there throughout the day. I think we can have some more information, a lot of expertise they hold and a lot of experience they have.
I think if it's a lower tract, anything, maybe urethral whatever, I think it's still, even after the surgery, the first thing we should tell the patient that this is the beginning of the story, this is not
Right, not yet. So,
once they know that, I think it's.
so normally when we were so long time, we thought PUV is operating, ablation is the
It's the beginning of
beginning, now it's beginning, but we thought it's the end of the treatment, but then it's just the beginning. So any indication of putting child or this is a newborns for antibiotic prophylaxis indications?
So again, this is open to the house, I think debated area.
Now this is a very controversial issue, that's why I have just put it towards the end, whether you would want to give antibiotic as a prophylaxis or following the guidelines or you want to.
So if there is a guideline for the by the ICD for the primary view, but with these cases there no viewer, but there heavy mix of secondary influx of viewer. So that need to be concerned and you can do a prophylaxis.
So take home message is that any antenatal hydronephrosis remains a clinically challenging diagnosis and risk predictions. So all infants who have been detected to have antenatal hydronephrosis should be evaluated properly and should be monitored properly through USG and other imagings. Postnatal follow-up is very important, and the outcome depends on the underlying, pathologic anomalies, and any clinical intervention can be done in selective cases only and in only specialized centers. And long-term outcome with mild antenatal hydronephrosis, as we have seen, many of them spontaneously regress, and that's good. So don't need to be panic. And then severe antenatal hydronephrosis needs more aggressive management.
I think we just reiterate that even in unilateral hydronephrosis, if the postnatal scan done within after 48 hours is normal, we should still take a message that at 6 weeks or at least after 4 weeks, there should be a second scan, because there have been instances in which postnatally they look normal and the patient is discharged out of surveillance, but they come back.
There are many times it does happen.
Yes,
So need to follow it up maybe at 6 to 8 weeks, and again if required at 3 months, or again maybe 6 months is also okay. Right. So proper monitoring and following up with the USGs is very important.
Can we have a take-home message added over here, if possible, between day 2 USG, post-entry USG, and 4 weeks USG, when the baby is going home to the post-entry ward, does the baby go home on antibiotics? Yes or no?
With a child on antibiotics.
Does the baby go home on antibiotics?
So this is
Because this is a very contentious issue, I agree. But this is an oft-faced dilemma. Day 2 abnormal postnatal scan, going home, coming back at 4 weeks for a repeat investigation.
Should the baby on antibiotics or not?
Should this baby go home on antibiotics?
The recent guidelines is here, if it is a very mild hydronephrosis, that is less than 10 millimeter, then the baby, the recent, I'm talking about guidelines, then the baby does not need antenatal, prophylaxis. If it is moderate to severe or there is associated reflux, then the baby does it.
Severe hydronephrosis, maybe if it has more than 10, or bilateral gross hydronephrosis, then unilateral also, if the epidiameter is very high, then unilateral.
Very interesting discussion, but what happens is when the first thing that happens when you are on the other side, whenever these patients come with having an ultrasound and primary scan at 19 weeks with the dilated kidney, the first thing they come and tell me, "Sir, bacha ki raat ko nosto kar do."
That's what
And that is a very, and so the first counseling is what we do to them. We start the counseling process and we start the referral mechanisms. Because we have a good referral system in the hospital. I usually refer them to Dr. Stina or Dr. Subhasis, and they usually take it from there. And if it's in India to Dr. or Indo, and they take it forward. But the thing that I always tell them, that so long your lighter volume is okay, so long your baby, there is no other evidence of any sort of obstructive uropathy, we are not going to deliver your baby. We are not going to have an iatrogenic premature baby. Because what happens is sometimes some pediatricians I have seen in my own experience, if the renal cortex is very cleaned up and Dr. Somebody is saying that, I usually understand that your UTD classification. So if it is the severe grade and the renal cortex is very thin, the kidney function is getting poor, and my pediatrician, if the person you want to refer that case to, they tell me, deliver kori. And this is something I want to avoid. I don't want an iatrogenic premature because I know so long as the lighter volume is normal, I will not deliver because I know that it is so.
Exactly, sir. And that's what the guidelines also say. You can keep the pregnancy period down, not to downgrade. That's what Dr. Rana has already suggested at the counseling. So thank you so much, Chairperson sir and ma'am, and thank you so much for my expert panelists who have put in a lot of expertise and information that you have got here. It's learning experience for me as well. So thank you so much, and thanks for
Thank you for making it interactive.
Yeah, any questions from the audience, you can take it up. Maybe one.
Yeah, we're ready.
Any questions from the audience? Any queries? Or all the puzzles you think have been sorted out? Okay, thank you so much.
Okay.